Our next speaker is Dr. Satyajit Sinha, who again needs no introduction, who's a chairman of the ABI Institute, Patna, and he's also member ARC East for the second round and quite a national figure. And he's going to show us a very good teaching video. On to you, Dr. Satyajit.
I would like to take this opportunity to thank Dr. Chitra Ramamurthy for giving me this opportunity. I'll be showing a video on posterior polar cataract, and each of the entries that we are making is very important when you are doing a posterior polar cataract. Even in this video, I have showed over here like I'm wriggling and going in, which is not the best way to be doing it. It should be a smooth entry in one go. There should be no leaky wound. You should fill the viscoelastic properly. And it's very important to make a good rexis. And the rexis also should be of such size that in case in future you need to do IOL capture, the rexis should take the IOL for the IOL capture. But sometimes I make the rexis a little bigger so that when these cataracts are soft, which they do not have any nucleus, just the cortex, so it is easier to remove, and there is less stress on the posterior capsule at the point where the PPC is. Then we slowly go ahead and do hydrodelineation, and before doing the hydrodelineation, we remove a little viscoelastic which is there in the anterior chamber. Once we have seen these golden rings, which you can see in this video, that gives you an idea that hydrodelineation is properly done. And then we shave off the cortex from, we start the phacoemulsification process. And slowly I use my second instrument also to move the nucleus which is there, so that we can turn it around and bring it into the phaco probe. Because the rexis is a little bigger, it makes it easier for the nucleus to come into the for phacoemulsification. Now, once you have completed that, do not come out without filling the viscoelastic, because that will put some pressure on the point where the posterior polar cataract is. So the anterior chamber should be always fully stable. And then you go ahead and do this cortical removal. Even when I'm doing the cortical removal, you will see that I do not go all the way in removing the cortex until where the posterior polar cataract is. I only pull it and bring it to the point, to the central point, and then leave it, and then go to another quadrant to remove the cortex. Because I don't want the pressure to be happening at the point where the posterior polar cataract. Once the whole cortex has come in the center, already a lot of fluid is circulating in the bag, and that also helps in releasing the cortex from the posterior capsule. And then you finally slowly remove all the cortex which is there. And at all times, we have to make sure that we do not let the anterior chamber, we have to let the anterior chamber be as stable as possible. Once we have removed this, again, we have to chamber so that there's no this thing. And just like Dr. Sanjay was showing, even now, once you have finished that procedure, you still have to be very careful of how you are loading your IOL. Even when putting the IOL inside, there should be no sudden jerk, and it should be implanted smoothly because the posterior capsule at that point of posterior polar may be compromised. Right now, when we are putting these premium IOLs also in a posterior polar cataract that you have promised to the patient, the pressure is even more that nothing should happen. And even until you have completed the case of the posterior polar, even while doing the hydro for the cornea, there may be a posterior capsule rupture. Even when you are putting this IOL into the bag properly, you have to be very gentle and you have to make sure that the IOL is in the bag. The little cortical material that you are seeing on the posterior capsule behind the IOL, once you have finished removing the cortex, do not remove it at that time, because the capsule is compromised over there. So now once you are removing the viscoelastic, this is the time that you can clean the posterior capsule and remove the remove the cortex that is there behind the IOL on the posterior capsule. So these are the points I wanted to share. And even when you are doing the hydrodissection, it has to be very gentle so that there's no pressure on the posterior capsule.
Thank you very much, Dr. Satyajit. That was a wonderful video with a lot of very essential tips across. For the panel, just for the sake of discussion, supposing you have done a good multifocal IOL in a polar cataract and the other eye, you've had a PCR during IA. Now, Dr. Chandrasekhar, how would you manage that particular case? How would you do that?
Yeah, first of all, I would have counseled a patient that such a possibility always exists. And if I feel that the PC rent is not able to, I am not able to convert into say a posterior rhexis, I would go ahead with a multi-piece IOL in the sulcus. If I can...
multi-piece multifocal?
3-piece multifocal is not easily available.
Yeah.
That is the problem. So that's why unfortunately you have to go with a monofocal. But the best point is to convert into the tear into a proper rhexis. However, in
a polar cataract, it gets difficult. It's a vertical slit.
Exactly, it is very easy, not very easy.
Yeah. We have access to, as of now, to 3-piece multifocal IOL. But supposing if we do come to a point when we do not have access, Dr. Ramurthy, what would you suggest? Would you try to make the patient a little myopic for the monofocal if that kind of a setting were to happen? How would you deal with it? Would you want to give him better near vision or would you want to give him distant vision?
No, it's definitely a compromise situation. And, we have to, if we don't have the 3-piece multifocal, we have to put a 3-piece monofocal in the sulcus and create an optic capture. And obviously, we have to explain to the patient the situation. It has happened to us, and we have even used a scleral fixation of a multifocal intraocular lens when we are forced to do this. And a couple of these patients have done well also. That's not something we'll recommend or talk from a podium, because even mild decentration, these lenses are very sensitive to it. But if I may make a comment on a very nice case, Satyajit, that you showed, just a couple of things and maybe just add-ons is that, once you have did a nice hydrodelineation and remove the nucleus out, in that case, I won't mind even doing a visco dissection, because once the capsular bag is opened up and there's no pressure on the posterior capsule, then sometimes removing the epinucleus and cortex becomes quite sticky. So doing a little bit of visco dissection mobilizes that and removes it more easily. And as you rightly pointed out, when there are small tags on the posterior capsule, unlike in other cases, you resist the temptation of polishing it, because that itself may make the posterior capsule give way. But what I do in these cases is, once the capsular bag is, before putting in the lens, I do a bit of hydro polishing. Just use a flush of saline on the surface of the posterior capsule. And if it's a fibrotic patch, it doesn't come away. But many of those small fibers and floating patches, is when you direct a flush of fluid there, it does come off and gives you a cleaner capsule. And then you can implant the lens.
Would you believe that in all posterior polar cataracts that we should definitely do an AIOS to understand that how the posterior capsule is, and that would be a very important investigation tool for polar cataracts. And based on this, if you see a polar cataract, would that mean that you would try to advise a cataract surgery earlier on to our patients? I think that has yet happened, but should we think so that an earlier surgery would help? Is my thoughts to the expert panel.
ASOCT will definitely help.
No, earlier surgery for the polar cataract.
Earlier surgery also, it definitely helps, because the maneuvering is very simple.
Yes.
And you have to be enough place.
No, I won't agree with that. Definitely do a ASOCT that gives you an idea whether it's going to be more risky or whether it's a fibrotic patch and the posterior capsule is intact, in which case the chances of PCR occurring is less. And if it's open and you can see lens matter, in the anterior vitreous, then obviously it's a pre-existing dent and you have to be prepared to deal with it. But sometimes you just see a small neck of a PPVC and the patient is quite comfortable. So in these cases, I think you should actually hold on. I mean, why unnecessarily expose the patient to a risk of having a open PC and putting a intraocular lens in a compromised situation? So we wait for the patient to have a problem and then go ahead and do this. And most often PPC comes with fairly softish cataracts. You don't very often come up with the hard cataract, the PPC.
Yeah.
So I would rather wait for the patient to start complaining about the vision drop rather than do an early surgery.
Yes,
Right.
actually, I meant that only, that once the patient starts complaining,
Yeah, then
there's
of course.
no point in, yes.
Yes. So thank you very much, Dr.
I want
Satyajit.
to take 1 minute. I want to thank Dr. Ramamurthy, sir. Afternoon after afternoon for all our webinars. Sir is always blessing us with his expert comments, and he takes out so much time for academic and research committee. Sir, we are very, very grateful to you for your time and all your comments that you give in our programs, every ARC program. Thank you so much, sir.
Thank
Yeah.
you, Satyajit. It's a
Yeah,
pleasure.
that was nice of you, Satyajit. It is often getting difficult for me to keep him as an expert panel nowadays. Thank you.